Hello. Hello, everybody. Thank you very much for coming. First of all, it will probably sound like I'm having a stroke as I'm talking. This is because half my face is numb. As I gave a dentist a lot of money this morning. I decided I'm going to come back and be a dentist, as I see. But anyway, and thank you for the waves of sympathy I received from all of you at that point. Okay, we've got some fantastic presentations around the census, around our strategy, the values, and of course SWIFT. So I'll keep my comments very, very brief today. Can I ask you all to make sure that you read my blog, if you've not already read it this week? Because a lot of staff have come up to me in the last couple of weeks being very seriously wound up and upset about hearing in the Manukau Courier about the $100 million deficit that we don't have. Okay, and that's incredibly upsetting and unsettling for staff. We don't have a deficit, and we're on course to break even this year, as we always have every year. And we'll continue to do so, and we'll continue to do so by being creative. We'll continue to do so by working smartly within a strategic framework, and we'll continue to do so by tapping into the ideas and the skills of people at the front line. What we won't do is we won't chop bits off the organisation like mad, as a way of just balancing our books. We won't do that. We'll keep our strategic shape, and we will thrive in difficult times. We've done that the last 4 to 5 years, and we will continue to do that, and that has been the most successful way forward. And as one person said to me, whenever I hear somebody saying, why don't we just overspend like other DHB do, then the reaction is, well, why don't you go and get a job in that DHB, and we'll keep yours open for 6 weeks and see which one you prefer at the end of it. If we remain in control of our own destiny, then actually we get to make the right choices for ourselves and for the people of South Auckland, and that's why it's so important. And we have some really difficult choices to be making in the next few months, but I want us to make it in a positive and creative way, and not in any way that's threatening and punitive. Okay, some difficult decisions, and we will make them, and we will get there, like we always do every year. So let's just please take away that message. The other thing I would like to say finally is I woke this morning to some very, very sad news. I just saw Terry here, Terry Rings, and that Terry Pratchett died last night. And as I have all 40 of the Discworld novels, I haven't read any of them. It's Sam who's read them all, and she's got an encyclopedic memory about them. So I think for those of us involved in the Discworld world, like Terry and I, it's a very sad day. So just want to acknowledge the passing of a great entertainer. On that point, I'll pass on to Doon to talk about census. Thank you.
Tēnā koutou katoa, a ngā mihi nui kia koutou. For those who don't know me, my name's Doon Wynnard, and I'm the Clinical Director for Population Health here at the DHB. We're going to talk briefly about something that was unexpected from the 2013 census, and then some of the things that we think were a bit more expected. So in terms of what was unexpected, we have a picture in our heads of our population, the size of our population, the mix of our population, and the picture that we had in our heads before the 2013 census came out was based on projections from the 2006 census and on our utilisation data, things like our PHO enrolment, and also we can link together all kinds of data sets to get a picture of the people who are using the services, the people that we're providing services for. So we had a picture in our heads, and what happened is that on census night, the number of people who filled in the census and said that they lived in our country's Manukau area was actually less than we were anticipating. So that has played out into what happens after the census is that number on the night gets adjusted for various things, and we get a set of estimates and projections for our population both at the time of the census and going forward, which are the ones that we use for planning and the ones on which we are funded. And so the fact that less people said they were living here plays out in this kind of way. So if we just walk through this slide, the brown column here is the estimate for our population for 2015 based on the 2006 census. And so what we thought we would have is around about 529,000 people this year with a particular population mix. When the 2013 census results came out, that estimate for 2015 was updated, and you can see that we've lost, in inverted commas, around about 1% of our population, about 9,000 people. But importantly, we lost that in a different way across our ethnic groups. So we lost about 5% of our Māori population, so just over 4,000 people. We've actually lost kind of 9 to 10% of our Pacific population, nearly 12,000 people in the estimate for this year. We've lost a few in our Asian population, and we gained, in inverted commas, about 9,000 people who we in New Zealand, European and other groups. So it doesn't actually change the percentage in terms of our mix of our population much, but it does within those groups. Those are quite significant changes. The other things just to note on this slide is that I've circled here, we still actually serve a really large population of children and young people. So we are a youthful DHB. We are 23% aged under 15, compared with about 20% nationally. We are still really diverse when you compare us with the New Zealand population. And if you look, for the people on this side, if you look out to that far column, we're about 11% of the total New Zealand population, but we're nearly 40% of the Pacific population of New Zealand, whereas we're actually only about 7% of the Pākehā population. That's what that column is telling us. So we are diverse. We're going to come back to that. We have lots of children, and we also have, one of the things that really stands out for us compared with other DHBs is the proportion of our population living in what we call NZ DEP 9 and 10, which is the most socioeconomically deprived communities. I mean, you know this, you see it every day in your practice. It's the sheer quantum of that group which makes us stand out from other DHBs. So it's the 36%, according to the last census, of our population were living in those areas. There are other DHBs that have a higher proportion of their population and living in NZ DEP 9 and 10, but because their total population is so much smaller, you take somewhere like Tairāwhiti, they have in the 40% living in that, but actually it's only 22,000 people living in NZ DEP 9 and 10 because of the total size of their population. So it's the quantum of our people who are living in poverty in really challenging circumstances. If we say, what does that kind of picture mean in terms of service demand? So there are different versions of the population. We think that actually our utilisation data tells us that our population is bigger than the census estimates tell us. But whatever version we look at, there is growth. So there's growth at a total population level of about 1 to 2%. For the 65 and overs, it's about 4 to 5%. That growth is actually projected to be a bit slower going forward than historically the projections had been. So not only is it a bit lower base, but actually the growth is a little bit slower. But it is still growth. So we can expect that that's going to drive health service demand of various sorts, whatever other factors are in the mix. There's a whole range of other factors about technology and obesity and all kinds of other things, but there will be some growth from that. We do need to remember that even though our childhood population isn't growing fast like our older population, we still have this very large population of children and young people, a really important time in their lives. And the other thing is that actually 45% of them are actually living in NZ DEP 9 and 10. The other thing we all know is that many of our long-term conditions are actually impacting our population in their middle years. So even though there's a lot of growth in that plus 65, the middle years are actually really important. That's what was a bit unexpected. If we look at this slide, it's trying to capture some of, I guess, what we could say which was expected around our diversity and the poverty mix, that it actually varies across the life course. So if you look at those pie graphs across the bottom, how you experience the population of counties in terms of the ethnic mix will depend whereabouts in the population kind of age area you actually work. So if you work in children and young people services, the pie graph on this, your left, it's very diverse, whereas if you work in older person's services, you can see the pie graph at the other side is actually 2/3 of that population are actually Pākehā. So the mix does vary across our age groups. Also, the number and the proportion of people living in poverty varies across our age and our ethnic groups. So that bar graph is actually saying 45 total population, kind of the 36% living in NZ DEP 9 and 10, but kids it's 45%, older folks it's 25%. So again, the mix that you see will depend on the age group that you're working with. And in terms of our ethnic groups living in NZ Dep 9 and 10, Māori, it's nearly 60%, and it's 76, 78% in our Pacific population. So that reflects in the kinds of things that we see about the mix of risk factors of diseases that relate to the conditions in which people live. So I just wanted to finish in terms of saying we do have a very diverse population. We do have a population who are living in incredibly challenging circumstances, and we do experience that and know that every day. In terms of thinking about equity, often I think it's hard for people to get their heads around the fact that when we're talking about trying to achieve equity, we're not actually talking about trying to treat everyone the same, to treat everyone equally. That actually to give people the same chance for a good outcome, we actually have to be prepared to treat people differently. One colleague said, you often read in a document, particularly often quality documents, will say that we treat everyone the same, irrespective of gender, socioeconomic status, ethnicity, irrespective, regardless. What she said is maybe we should be saying, actually, we treat people respectful of their ethnicity, their gender, where they live. And this picture is just trying to capture the idea that actually if we are respectful and regardful of people's circumstances and their need, then actually we do have to be prepared to do things differently for different people. So if you look at the one picture, the little chap has no chance of seeing the game because the resource has been distributed equally. But actually, to have an equitable chance of seeing the game, the resource is actually distributed according to his need and he gets to see over the fence. You could argue that we could ask why the fence has to be there in the first place, and that's another whole conversation.
I think Doon's right. I mean, the review of the formula that leads to our funding is ongoing, and as you can imagine, it's a very complex beast. I think one of the reasons why it's a very complex beast is that, first of all, you can't have the law of unintended consequences. Because if you sort out a formula and put it into place, and suddenly a big hole appears somewhere in the country because of that particular demographic they've got, so there's got to be some kind of sort of cognizance of that. But also, I think if you go to Dunedin or you go to other places, particularly South Island, it's the population is static or shrinking. It's aging, Pākehā, whereas here it's a much more different dynamic kind of game. And as Doon has just identified, so the issue is how do we get one funding formula to rule them all in a way which meets people's needs in a sensible fashion? And the answer is it's becoming ever more complicated, and I'm not sure if one simple formula or one complicated formula will answer all of that. We'll have to see. I mean, it'll be interesting, I think, when we get to the relevant landing to get Wing, who's in Doon's team and on the team doing the review, to actually give us some insights into some of the discussions. Yeah.
I was just going to ask you in terms of the relevant...
Okay. Tēnā koutou katoa, ko Marianne Scottahau. Welcome. I'm the Master Planner for Counties Manukau. Does anyone know what that job means? Well, I've been learning long and hard over the last few years. So my job is really to try and connect all of the planning, and there's many plans. And it's what's really important with strategy is around making some deliberate choices about how we choose to be different, looking out into the future, recognising that we have near and present things to deal with today. What you've seen nicely with Doon's slides is some things are constant for us, so we're refreshing our strategy. We're not starting from scratch. Our population remains young. We may not have much of a change in our population for young people, but that's a huge percentage of our population, and we need to know that we are doing the best we can as a health system. And likewise, socioeconomic deprivation will remain a constant. So how do we do better with that persistent equity gap? What does that look like when you look at strategy? So the strategy refresh process that we're going through in the next couple of months, and we want to work with as many people as possible and say, in looking out to 2020, these are the areas that we're going to choose to be different. When you join up all of the things that you've heard about, like localities, community health integration, 20,000 days, Manaaki Hauora, or the Project Swift. What does that look like when you put it all together? And is that the smartest way we can make the most difference with the resources that we have? So part of that is to come clean around the decisions we've already made and have a debate about the things that we need to scale up more, do something faster, and if we do that, what do we need to stop? Because we know that we're not going to get any, what we've got was what we've got today. It's about being really smart and looking at building on what we've achieved already. So in terms of where we go to from here, you'll be aware we've got our current strategy, and that finishes, we are actually here, December 2015 is this year, and so we will work this year, Ko Awatea is leading the evaluation of how we have tracked and how we've gone with that. So what we need to be able to do is have the discussion now, so we can stand up at the beginning, the middle to the end of this year, about what is that next phase of strategy, what does that look like? We will try and do our best. Actually, we're not going to do our best. We are going to achieve a clear story that everyone can understand. That's not just us, because we're a really complicated system. We need to take some of that complication out and respect that how do we make the difference, the biggest difference for our population whose lives are frequently complex. So how can people get involved? We've got kind of my boss's Margie Apa, Director of Strategic Development. There's 3 bites, to use her terminology. The first one is to say what truly will look different if you come to work or our people come to our services in 5 years' time. What will look different? We need to tell that story really clearly so that we can focus our energy and efforts. Then the crunchy bit is the strategic plan. When you start to put everything together, and the words that people have used in talking with them over the last couple of years is, Murray, and I want to know how they fit together. You know, have we been really sharp and transparent about how all those bits fit together? Does it make sense? We've got some wicked smart people here. Have we really made the best that we can with that? Then the really important part, and we've learned a great deal about what works and doesn't work. Strategy has to remain a little bit agile because we are a learning organisation, and we need to be able to ensure that we have some really clear steps that are measurable goals and efforts to get there, but we need to remain agile for things that come up, opportunities that we didn't expect, and also to learn about what works for the people in our community, what works for us as a system, and that means the broader health system. Do I get points for finishing early? And then I think the most important thing is actually getting it done, making it happen, being real about our resources. And so that'll be really putting up quite clearly, actually when you lay it all out, is this the smartest way to do it? And let's have an honest conversation about that. And that's my seconds. So hopefully I've done it in time. I'd be delighted to take any questions.
Sometimes when you're talking about strategy, it sounds a bit sort of esoteric and how meaningful is this for us. Actually, what we're trying to do is to tie together what our priorities are going to be for the next 5 years, and that's linked to the decisions we're beginning to make now about the areas that we're going to be investing in and what happens with our finance position, the bits we're going to do and the bits that we're going to stop doing. So it's very, very important that people get involved in this debate so you can see your part in it, you can get your voice in, because if you don't, and if we don't, we'll have to make some key decisions. And I don't want people to feel that they haven't had the opportunity to input to this, because out of this will come things that we're going to concentrate on, things that we're going to not concentrate on, and things that we're simply going to stop doing. So it's very, very important that you're actually all part of this process, and it's very meaningful in terms of what I started off talking about in terms of the financial position, because these are all the things that we're trying to balance within the strategy. Beth.
Okay, hi, I'm Beth. I'm still relatively new. I think I've been around about 16 weeks, and I'm GM for Human Resources. And I'm going to start by saying I hope you've seen these around the hospital. The piece of work that I am responsible for brokering across this organisation in the next few months is the renewal or the review of our values. And really it goes hand in hand with Marianne's piece of work around the strategy, because this is about how we do our work and how we will do our work into the future. I haven't been here long, but I've been told that the last time CMH focused on this piece of work is 1990 something. So it's timely. We need to engage with you as our employee population and with our patient population to find out what is it like when you work here and what is it like for a patient who experiences our care. So we started this work in January by looking at every single patient complaint and patient compliment that this organisation received last year. And this is the response from the compliments. These are the consistent words that were said by our patients when they wrote to say thank you for the care they have here. And some of these words are great, and we want to see them bigger and bolder. The one that was the complaints is not one we're putting around the hospital, because clearly it might not engage our patients terribly well. But what it did show, and you will see it if you come to the sessions I'm going to talk about shortly, is that this isn't consistent. This isn't consistent with what the complaints said. And so this is about how do we engage all of you as staff members on how do our patients and whānau experience consistently good care in this DHB. Okay. So, how do you engage in this part of the process? Back. On your chair, you sat down today and you have a graffiti board or a survey, however you wish to call it. And it is promoted every day in Daily Dose, and it's on the front page of the intranet. And if you log into Kiosk to get your payslip, there's a link to it there. And I really encourage you to tell us what you think, to give us your feedback at this point in the process. We can't make this successful and do this with integrity without your feedback. So please take the time to fill in the questions and tell us what you think. It's an important part in the process. We're also surveying patients. We're working with the Patient and Whānau-centred Care Board, and we will be very active in the Patient Experience Week to get patient feedback and whānau feedback on how they experience our care from that perspective. So take your time, fill it in. If you can leave it at the back, we'll in the feedback boxes. Please fill it in, it'd be great. And we've had 760 responses so far, and we're aiming for 3,000. To encourage you, if you like the gym, there are 4 free annual memberships to Club Physical, and we're endeavouring to find more prizes as we go. So the survey closes on the 8th of May. So that's about engaging you, about getting you thinking about what it's like to work in this DHB. And then in April, we are going to listen. And we're going to listen to you, and we're going to listen to our patients and whānau. So you are encouraged to also sign up to attend one or more of these sessions. Probably don't go to one of the same type. There are 3 types. There's the In Your Shoes session, which is about the opportunity to listen to patients and whānau about what it is like to be in our care, one-to-one. It's supposed to be a really engaging session, particularly for clinicians, to really hear what the patient has experienced, to get a different view of their experience post the event when they've had some time to reflect on how they actually experienced our care. Then in our shoes, I want to know, what does a good day look like for you? What makes a good day? What behaviours do you like to see from your colleagues? I also want to know, what makes a bad day? We all have them. Every single one of us has a bad day at work. I hope that you don't have them often, but some of you might. And I want to know what made that bad day. What behaviours did you see in our staff that you think should change, be different for you as a staff member, but also for the patients? So there are a number of sessions that are specifically focused at different parts of our community as well. So we have a couple of sessions happening on a marae and a couple of sessions happening in a Pacific church in South Auckland as well, in Papakura. And we have some sessions happening here and at the Manukau Super Clinic to try and give everybody an opportunity to attend. I understand getting time out of your clinical job is not an easy thing to do, but the more effort we put into this, the better the outcome will be around the work that continues after June. So once we've done this process, which is the listening part, we'll move into distilling what we've heard and what we've gathered in the first 2 phases. And around the end of June, we will present to ELT the reviewed words that will come out of this process. And then the real work starts. At that point, it's about embedding our values into this organisation. How do we live this with integrity? How do we do this so we're not using the values as a shield, saying everything's fine, we've got values, and we're not using them as a sword to maybe attack other people's behaviour. We really want to work out together, how do we live these values with integrity, so that essentially our patients receive consistently great care, which will contribute to great patient outcomes. Do you have any questions?
Just looking at that, and it's been a concern to me because it's lying on my floor when you go into the care centre, you're walking all over our values. But there aren't any Maori concepts there. There's no Maori values there. So what I want to know in terms of treaty partnership, how come the Maori values are only now beginning to
So we have discussed that matter at quite length. No, it's fine, absolutely fine. We have a working group who meet about fortnightly, and there's representation from every area of the hospital, and particularly from Māori and Pacifica. So we have asked that question about what did we do with this? But actually, these were all the compliments. There were, unfortunately, no Māori words or other Pacific Nations languages in the feedback that we received last year at all. So that's not how we want to reflect it going forward. So there will be a very long conversation with Ricky and his team and Elizabeth and her team and the stakeholders around how do we reflect that in our values going forward. It's yet to be determined, but we want to accommodate it. Yeah. That is one of the reasons why we're hosting 2 sessions on a marae, so that we can enable that to happen. Okay. Great. Thank you.
I'm a surgeon, I'm pretty loud, so I'll try and do this without a microphone. Matthew Clark, I started here as a 4th year, just around the corner under the care of Roger Reynolds, and kept on coming back in many different roles and love the place. I consider myself very committed to this place. I live in a different DHB's catchment zone, but if I was to be unwell, I would come out here. I think we provide superb care to our people, and I'm really proud to be part of it. I've been asked to talk about the SWIFT process. And I can't talk about the SWIFT process because it's huge, and to be honest, there are aspects of it that even me being involved, I still don't understand. What I do understand is that this is probably the single best opportunity that we've had for a generation to make some significant change to the way we do things here and to improve patient care and patient outcomes. I'm going to tell you a couple of stories. When I was 12, going back a few days now, my father took me to see Star Wars when it came out in Queen Street. And we were living on Waiheke at the time. We came up on the ferry, we walked up Queen Street, we then stood in a big queue, and we saw a fabulous movie. And the first time the big Star Destroyers went overhead and the cinema rumbled. This was new technology, this was awesome, and you were just so immersed in it. I don't know if many of you know, but at the end of this year, the next Star Wars movie is coming out. Okay, it's going to be fabulous. But instead of standing in a queue, what I'm going to do is log in on my computer to Event Cinemas, and I'm going to choose the session that I want to go to. And then I'm going to choose the seats. Then, if I want to, I can order my popcorn or a beer if it's the right cinema, and I'm going to be able to go there knowing with certainty that I can see that fabulous movie with my kids, get it done. Now imagine if some of our patients who are coming to a clinic these days could do the same thing. If they could log in when they're invited to come and see me in a surgical clinic, and they choose their own time, maybe language specific in their own languages, choose the time that's convenient for them, choose the time slot, maybe even choose the location. Wouldn't that be fabulous? Now we've got the technology to do that with movies. Why on earth can't we do it for healthcare? Now, I'm wearing a watch that's 70 years old approximately. I love collecting old technology when it works. I collect old tools. When we decommissioned the Middlemore theatres, there were boxes and boxes of these beautiful tools that were going to be thrown out. And I grabbed probably 4 or 5 boxes, with permission, of course. But you know, they're beautiful tools, but we just don't use them these days. We've got different tools. Now with a watch, many of you have probably got watches, but some of you have switched to not using a watch because we've got the same tool on our phone. Now, a week ago, earlier this week in fact, the Apple Watch was officially launched. And now you've got something that we call a watch, but it's actually a new kind of tool. It's got information technology within it that can do different things. It can measure your heartbeat. It can tell you how many steps you've made today. It can do all sorts of things like tell you how many stairs you've gone up. It's got accelerometers that know when you're going up the stairs. This is the first generation of a new device, but can you imagine in a few years' time, if this can check blood sugar, if this can do other things that are healthcare related. This is a $350 device, which is less than what it costs to have somebody in the hospital for a day. So we're now at a time where we can give people the right tools to save them money, save them anguish, and all sorts of things, and it's going to be useful. It's a real shift. Things often go along steadily for a while, and then suddenly everything changes. And I think the SWIFT process is going to be one of those sudden changes, and we've got a wonderful opportunity to make the most of it. Last story. Today I was in clinic, and I saw 2 people that are dying of cancer. And it's an important part of my job. As a surgeon, you'd think surgeon, operator, you know, that's easy. That's only a small part of what I do. A lot of it is talking to people and communicating to people. When I was communicating with one guy, I'll backtrack for a sec. Gloria, I think, thank you, sent out some wreath lectures by Atul Gawande, who is a medical author, surgeon, but he's a nice guy despite that. And he's looking at all sorts of aspects of healthcare these days, including end-of-life care. And I was listening to that in the car a couple of days ago, and today I'm seeing 2 patients that are dying. So I thought, he was telling me I should be doing less talking and more listening. And I tried to do that today. When I did that, I was horrified to find out that one of the guys that I was seeing had 2 big issues. Atul asked me to ask the patient, what are the issues that affect you? So I did. The guy said 2 things. First, I'm getting all these appointments, but nobody can tell me what they're for. We've got tools that should make that better. The second thing he told me is that the GP had cut down my pain medication and I'm in pain. And that was the thing that was bothering me. Now, what I want out of SWIFT is I want tools so that this guy comes to me and he knows why he's coming to me. Maybe at a time that he has chosen. So he comes in knowing what he's there for and knowing that he's had some input into it. And what I want is tools that I can then communicate with a GP or direct to a pharmacy to give the guy what he actually needs, which is pain relief. It should be simple. Currently it's not. Why am I involved in SWIFT? I want to make things better. I want to try and drag all of these things in. The technology these days is there, but we've got to define the human aspects of it. We've got to define the outcomes that we want so that we can give our patients and our community the best results we can. And I'm really excited to be part of that process. Thank you.
Thank you, Matthew. One thing I just want to quickly mention is one of the things that we've been working on is making sure that the work that we're doing here in terms of IT and the work that's going on in the other DHBs in the Northern Region get lined up. At the moment, as a regional process, we've been going through identifying what would be our PAS, patient administration system. But we don't just want to have a patient administration system, we want something that can do a bit more than that, that is going to be future-proofed. So to enable to make sure that not just the GPs in the hospital can talk, but the hospitals can talk to each other, because there's nothing more infuriating the idea that, you know, you may have a bit of your treatment here at Cairnsies, but if you then get further treated in Auckland, you've got to make sure that you're able to see all of that information in one go. So we've refreshed our regional strategy, and the aim is to align all the work they're doing so that we get all the blocks out of the way, and we can go really hard and fast and get the benefits of delivering this.
And I mean, we have been mindful that it could end up being a bit confusing for people, is that we're expecting, as long as all the papers go uneventfully through all of the boards, that over the next couple of months you'll start hearing quite a lot about the regional IT strategy refresh and what's being called the Regional Electronic Health Record Project. That there'll be quite a lot more information coming out about that, and some of that may sound as if it's actually trying to solve the same problems as what we're trying to address with Swift, and that's because that's true. Everybody's dealing with the same problems, and it is one of those things where it is important that that we're not just doing it in isolation from our regional colleagues, and that we ensure that what we're doing here is actually going to fit into that bigger picture. And so some of the people who are being involved in the Swift projects will also have opportunities to contribute to that bigger piece of work as well, and we're going to try and do everything we can to make sure that the whole thing basically gets lined up and joined up, and that we're not kind of either contradicting ourselves or duplicating things unnecessarily. So there's really going to be an awful lot happening in this whole area of how can we address some of the basic sort of process inefficiencies that frustrate everybody and have frustrated everybody for years, and ensure that we've got the IT in place that enables us to do that and actually drags us into the 21st century. How can we do that in a joined up way and actually see some real progress happen over the next 3 or 4 years right across the whole region? So it's an exciting time, I think.
Thanks, Gloria. I mean, if I can actually sort of connect together all of the sort of presentations that we've seen today and go back to something that Matthew said, that this is a generational moment. And that sounds all a bit dramatic and kind of, you know, and a bit sort of over the top, but it's not, actually. The world is changing around us incredibly fast. Our population is aging. Our population is changing in terms of how it demands service and what its needs are. And how we meet those needs is changing very dramatically too. And we have to respond to that in terms of our strategy. And we have to respond to that in terms of how we work on a daily basis. And we have to respond to that in terms of the world of technology around us and what it could do to help us do that. Now, the really important thing is if it's left to people like me to try and work out what that is, that generational moment will not be a great success. Actually, to make this work, we need everybody actually actively engaged in trying to change the world around them, actively engaged in that process. And one thing I'm really keen to do is to really encourage you to get involved in this. And sometimes it's a natural cynicism that we all have, oh, we're a bit busy, or they'll never listen to what I've got to say, and whatever. Oh, it's all been decided already. It hasn't. You are the co-designers of the future. And you've got to be part of that process if it's going to be successful, because this is about your working life and why you come to work in the first place, and why we are all in South Auckland incredibly committed to our communities. So this is a chance for all of us to actually have our say and get a real change happening as a result. And if we all, like crowdsourcing, if we all have our say, the answer will be better and more impactful as a result. And there's also a huge danger, we also might have a little bit of fun. And sometimes I think it's quite useful to have a bit of fun at work. And it would be nice to do that, I think, as an organisation. So this is a great moment for all of us, I think, to be involved and step up and shape the future. So that's the end of the presentations today. I just check if anybody's got any questions relating either today or any other issues they want to raise. All cool. Okay, well, I hope you've all battened down the hatches for the weekend. in terms of what looks like to be a pretty horrendous weekend. But I wish you all what you're doing to have a great weekend and look forward to seeing you next week. Thank you very much.